Okay, good afternoon, everybody. This is Shizuka Ko from Osaka University, Japan. It is my great pleasure to be invited to AIOC Symposium here today. So my talk is about understanding ocular biometry for cataract surgery in dry eye. I think this is one of the important topics. This is my financial disclosure. So as you experience every day, dry eye and cataract are very, very common in our clinic. So dry eye is a common disease that causes unstable tear film with an irregular surface. And also, currently, cataract surgery has become sophisticated surgery and not merely lens replacement procedure anymore. So why important? So this is a review paper from the ASCRS, American Society of Cataract Refractive Surgery several years ago. So what they say is insufficient ocular surface management can cause inaccurate preoperative biometry. And also it can cause poor post-operative results as well. Then it can lead to patient dissatisfaction for the surgery. So are you okay with this point? Okay, so today I organized my talk in the following way. First, I will talk about the impact of dry eye on ocular biometry. And next, I will talk about the preoperative screening for the presence of dry eye and abnormal ocular surface. So according to the DUCE2, I believe all of you are familiar with this definition. Dry eye is a multifactorial disease of the ocular surface characterized by the loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. Although there is no visual symptom, but actually ocular symptoms can include visual symptoms. According to the Asia Dry Eye Society, dry eye is defined in the following way. So dry eye is a multifactorial disease characterized by unstable tear film causing a variety of symptoms and or visual impairment, potentially accompanied by ocular surface damage. Here is visual impairment. So actually, all the ophthalmologists know that standard visual acuity test is not perfect. But however, in the real world, of course, general people and also non-ophthalmic doctors actually recognize that, okay, standard visual acuity test is actually good way to know the visual performance. But this is not true. Because one of the reasons is it is using the high contrast black and white letters. But in the real world, there are a lot of situations with low contrast conditions. So contrast sensitivity measurement is a measure of the ability to see low contrast patterns. Shown here is the contrast sensitivity chart, grading or letters at different contrast levels. Actually, it can estimate the visual performance close to real-world vision. Previously, we investigated the contrast sensitivity in dry eye. So if you rotated the contrast sensitivity chart 90 degrees, you can understand the result of contrast sensitivity chart very easily. So a green line indicates the result from normal, and pink is actually result from dry eye without corneal epithelial damage in the central region. And blue indicates the dry eye with corneal epithelial central damages. As you show here, so dry eye with corneal epithelial damage in the central region have a decreased control sensitivity and compared with others. Another reason for that standard visual acuity test is not perfect is because during the visual acuity measurement, patient can blink freely. But in real world, there's a lot of situations without actually less blinking. So we may have a possibility of the best moment visual acuity. Actually, in real-world vision, there are a lot of patients actually complain about fluctuation in vision. So since tear film actually constantly fluctuates, so we saw that ocular optical characteristics can be influenced. You know, since placebo-based topography uses the reflection of mirroring images projected onto the air tear film interface, so you can see you may experience that if you measure the dry eye patient, you may have such kind of distorted images. And if you actually have a chance to actually measure use the waveform sensor, it is also another way to actually see the influence from the tear film. On the left side, we previously actually measured the normal eye right after the blink and after the tear film breakup. So what we did is actually ask the patient, ask the subject actually to keep their eyes open for more than 20 seconds. So after the tear film breakup, you can see the distorted waveform spot pattern. And when we measure the higher duration sequentially after the blink every 1 second, you can see in normal eye, you can see the stable retinal images. But for the dry eye, you can see right after the blink, the retinal images are very actually decreased. Image quality is decreased, and dry eye has sometimes actually have very low actually tear film quantity, so there is no change during the blinks. So previous paper, recent paper actually reported that variability on ocular biometry from the tear film. So corneal curvature radius can be reduced in dry eye, and shortened breakup time associated with decreased measurement repeatability in corneal curvature radius and axial length. And also another press paper reported that tear film osmolarity can influence onto the keratometry data. Here is a paper from Korea. They investigate the impact of pretreatment for dry eye in IOL power calculation. So what they reported is pretreatment group had significantly lower mean absolute error in refraction at 1 month after surgery. And also they observed significantly lower refractive surprises. So next, we'd like to go for the preoperative screening. According to the Asia Dry Eye Society, dry eye can be diagnosed by the combination of symptoms and unstable tear film. So it is highly dependent on tear film stability. So just a simple tool, fluorescein, you can diagnose dry eye without any expensive fancy tools. Let's revisit the simple 3 steps in use of fluorescein. So please apply the minimal amount of fluorescein and shake well. Then apply please gently. So this is a very important thing to avoid kind of influence for the measurement. So again, there is no need for special devices. Just a paper strip of fluorescein helps dry eye diagnosis. So I'd like to share with you one case after the surgery. So this patient actually received the cataract surgery and a monofocal IOL was implanted. But right after the surgery, corneal epithelial damage occurred, and the referral doctor actually did a dry eye treatment, but they didn't actually improve. So he was referred without improvement with dry eye treatment. He had no history of systemic or ocular disease before. So this is shown here that his fluorescent staining for both eyes. So you can see the kind of dark area in the right eye. These shapes are map-like, and in the left eye, these are kind of fingerprint. Unlike tear film breakup, there was no movement. So this is a case of epithelial basement membrane dystrophy. Redundancy of the cells within the epithelium form marks cystic dots or an irregular fingerprint. So this is also called as mapped London fingerprint dystrophy. So this is one of the causes for recurrent corneal erosions. Asymptomatic but may become symptomatic following surgery. He was actually asymptomatic before the surgery, but right after the surgery, he became symptomatic. So in its earliest of stages, it is often missed without a very careful exam. So I highly recommend actually to use a fluorescent staining before the surgery to all the patients. Here is another patient. So she actually received the cataract surgery and multifocal IOL was implanted. But after the surgery, she couldn't actually get a good visual acuity. So previous doctor actually exchanged IOL to monofocal. But for some reason, he actually didn't see any improvement despite dry eye treatment. So she was referred to me. So this is her images. So we can see the kind of slight haze. I believe it was missed. So I asked the patient very carefully. So she said, "Oh, I remember when I was a kid, a stone hit my left eye and it hurt. And after that, I thought that my eyesight had not deteriorated." So I highly recommend to close carefully, to see the cornea very, very carefully, and do not overlook the very, very slight haze. So such as iron foreign body and post-ectasia and trauma. Some subtle or mild corneal abnormalities might be overlooked before the cataract surgery. So this is our previous results. So we prospectively actually screened all the patients before the cataract surgery, 101. And 30 patients are actually all excluded. But in the residual 71 eyes, we found actually corneal abnormalities in 60% based on the refractive screening criteria. Of course, this is a result from the university hospital, and also we have a bunch of actually variety of the surgeon and variety of the patient. We have to actually think about this. So again, this is very important. So it is up to you to screen the patient very carefully and use a fluorescein. So happy cataract surgery for dry eye patient, I suggest to optimize preoperative measurement and maximize postoperative outcomes and patient satisfaction. Thank you for your attention.
Thank you, Dr. Ko. Any questions from the audience?
Do you screen every cataract patient? Then do you do like the tomography on every patient, or is it just patients where you suspect something?
Thank you for a good question. So actually, so normally we did not do everything, every people, but for some point actually we are very interested in actually to know how actually the how much abnormality can be found even in the normal eye. But sometimes actually some very mild keratoconus patients know they have keratoconus just before the cataract surgery.
Perfect, thank you.
I have another question. When we are planning these patients for cataract, we are primarily talking about a difference of about a diopter in measurement because of the dry eye itself. So when you do diagnose these patients with dry eye and they get started on certain treatments, so what happens with the biometry? When do you do the repeat biometry for the IOL power, and do you do it on the day where they have used the drops, or they are without off the drops, because those also influence the biometric evaluations?
Okay, thank you. I personally actually didn't any kind of study actually to see the changes without pre-treatment or pre-treatment, but definitely when our technician actually say to me actually if they have some cataract preoperative measurement for another doctor's patient, and she said measurement are very very unstable. So when I asked to check that patient, there is a lot of corneal epithelial damage, so I suggest to postpone the measurement. Preoperative measurement. Then I actually gave that eye drops and asked the patient come over again. And when I see the improvement, I can suggest the patient actually you can receive the preoperative measurement.
So, I agree with that. I was actually going to ask something further to that. Would you recommend, just for the sake of the audience, that we treat a patient who has obvious dry eye for about 1 month, 2 months, 3 months before repeating? Or?
I think if it is not actually emergency, but if they have a kind of retinal detachment, definitely we should go to the surgery. But if actually this is not an emergency case, I think we can just wait for maybe at least 1 month. I think it is better.
Okay. Thank you very much.